Yes, this is the right one. Next slide, please. Next, please. Yeah, the background and the rationale about the paper, the setbacks in health gains and UHC efforts. COVID-19 has reversed hard-won health gains that have been achieved throughout the SDGs era by diverting much-needed and often highly limited resources away from health towards responding to the pandemic. Examples include the disruption of routine immunization for vaccine-preventable diseases, challenges to mental health, and the multiple health, economic, and social effects resulted with almost 71 million people being pushed into extreme poverty. A recent WHO survey reported that 94% of 135 responding countries experienced a disruption to essential health services, and that 48% of countries reported disruptions to services at the primary care level. COVID-19 has also exacerbated existing inequalities in health and socio-economic systems. Marginalized people, including elderly, people with disabilities, people living in poverty or in poor neighborhoods, displaced persons, and indeed those in fragile and unstable contexts have faced particularly tough circumstances during the pandemic. The lessons emerging from our experiences with COVID-19 are clear. We must invest in primary health care, as our Director General said, in essential public health functions, and prioritize the implementation of the international health regulations for emergency preparedness through an integrated, holistic, and people-centered approach to address the long-standing fragmentation between the health system strengthening and health security efforts. As WHO, we acknowledge the fact that we are presented with a unique opportunity to leverage the preparedness, response, and recovery continuum to promote the kind of integration needed between UHC and health security in ways that advance resilience, equity, and solidarity. Opportunities. Despite the complex challenges faced by the health systems worldwide, we now have windows of opportunities to make significant progress in building the resilience of health systems against future public health events. Some of the key opportunities include the heightened political attention to the health system resilience in all countries. Health is increasingly recognized as central piece in the International Development agenda by the G7 groups, by the G20 group, as well as other intergovernmental political forums. Demographic shifts, comorbidities, and chronic conditions call us to invest in primary health care. We have also learned during the pandemic that equity cannot wait, and primary health care entails equity, human rights, community participation, and community empowerment at the center of our work. We would like to recommend to leverage primary health care to reduce inequalities and essential public health functions. The pandemic has led to renewed commitments and efforts for international health regulations of 2005 implementation with all hazards emergency risk management. It has brought momentum to advance health innovation, including digital health, telemedicine, self-management applications, e-prescription, etc. Opened the space for new multilateral treaties, the International Treaty for Pandemic Preparedness and Response. And also multilateralism and intersectorality came into focus, whether on vaccine technology transfer, health and social care agenda, health workforce, and so on. Here, the Global Action Plan on SDG 3 is a platform for a stronger collaboration and synergy among 13 humanitarian, development, and health multilateral agencies. Next slide, please. Objectives and the target audience for the paper. The paper provides rationale and recommendations for building resilience by integrating universal health coverage and health security through 1. Investment in essential public health functions and the foundations of health system, with a focus on the primary health care and the incorporation of health security. 2. All hazards emergency risk management to ensure and accelerate sustainable implementation of IHR 2005. And third, inclusive governance to ensure community engagement and whole of society involvement. The target audience are heads of governments, political leaders, political elite, Ministry of Finance, and in brief, the opinion leaders. The paper itself has targeted towards key stakeholders, including civil society, private sector, parliamentarians, emergency managers, humanitarian and development partners, and the United Nations community. Next slide, please. The paper takes into account the lessons of COVID-19 and complements other response and recovery efforts within the United Nations, the UN Framework for Immediate Socio-Economic Response to COVID-19, and the UN Secretary General call for shared responsibility and global solidarity. The WHO Manifesto for a Healthy Recovery from COVID-19, which provides clear and actionable steps to support a healthier, fairer, and greener world as we work towards rebuilding health systems after the pandemic. The COVID-19 Strategic Preparedness and Response Plan, SPRP, which provides a practical guide that outlines the public health and essential health services measures needed to prepare for and respond to COVID-19. It also complements the emerging Universal Health and Preparedness Review mechanism, which has been proposed as a mean to increase accountability, solidarity, and transparency among member states in gap identification and capacity building for better health emergency preparedness, resilience, and recovery. And the work also aligns with the UNGA declarations, which highlights that only together can we build resilience against future pandemics and other global challenges, and calls upon member states to strengthen the resilience of their health systems as an integral part of their preparedness for health emergencies, so as to be able to respond to such emergencies while maintaining access to essential health services or to quickly reinstate them after the disruption. Position paper development. The paper was co-constructed by headquarters and regional offices, so it received a lot of inputs, reflections, and experiences from our regional offices as well as our headquarter-based colleagues. The principle of joint working will be carried forward as we support our member states and partners to implement the recommendations of the position paper. So I hand over to my colleague.
Thank you very much, Suraya, and I have the pleasure to invite Dr. Stella Chungong, Director of Health Security Preparedness, to continue with the presentation. Stella, over to you.
Thank you, Dr. Jacob. Thank you, Dr. Dalil. I will go through some key lessons that have been learned from COVID-19 pandemic and how they guide the recommendations of this paper, as well as how to mention the commitments of WHO in supporting emergency preparedness and response and resilient health systems. So a number of key lessons have been learned, and one of the primary lessons has been the need to improve the organization and functioning of health systems for pandemic preparedness. This includes building health systems that can surge to meet the demands imposed by health emergencies, including more robust mechanisms for governance, coordination, incident management, as well as addressing gaps in clinical management pathways, standards of care, infection prevention and control, and the ability to flexibly deploy workforce to areas of greatest need. The importance of maintaining essential health services and of limiting both COVID and non-COVID-19 mortality and morbidity cannot be overemphasized, and other speakers have talked about this. Investing in the foundational health systems gaps and essential public health functions for emergency management is crucial. Without sustainable, predictable, and flexible human and financial resources, priorities will not be addressed, basic service delivery will not be addressed, and populations will remain vulnerable to disruptions. National action plans, including for health security, will remain unimplemented. Effective governance, leadership, and decision-making have been critical during this pandemic. Governments that acknowledged the risks of COVID-19 early on and which had populations that trusted their leaderships and which made decisions based on available evidence and coordinated preparedness and response across multiple sectors seem to do better in stemming community transmission. A primary healthcare approach allows more flexible and more flexibility at local levels to address the constantly evolving situation. Emergency risk management is a common good for health, and this needs to be publicly funded. Public governance of health systems with predominant reliance on public funding sources is essential to enable progress towards universal health coverage and health security. Where these are limited, there is a high risk of exacerbating pre-existing inequalities in access, particularly when independent or private providers and insurers can set their own prices and exclude persons in the greatest need. Next slide. Building and maintaining public trust through community engagement and participation has been highlighted as being extremely critical during this pandemic, and highlight how clear, consistent, and reliable risk communications, proactive dialogue and engagement with communities, populations, and civil society can help to reduce public dissatisfaction and infodemics and increase their willingness to participate in all processes around the pandemic. Technology and new ways of organizing health services are playing a stronger role in providing alternative platforms for health delivery, service delivery, and pandemic response. COVID-19 has clearly demonstrated the importance of ensuring that health systems catch up with society in using innovative methods and new technologies. COVID-19 has magnified the inequity, health and socio-economic disparities, the disproportionately impacted, marginalized and vulnerable populations, and in particular, people living in fragile conflict and vulnerable settings, those under chronic economic downturn, who will need to have special considerations in harnessing global support and investments as part of resilience strengthening. Global emergencies compromise the scope for external support and resources as countries struggle with their own national responses. Severe global supply shortages and competition for critical medical countermeasures underscores the need to ensure that all countries are equipped with the necessary capacities to mitigate the impact of health emergencies and maintain delivery of essential services. Next slide, please. So in terms of the recommendations, the DG, Dr. Tedros, has mentioned these, but I would take them a little bit further in outlining what each of these recommendations entails. So in terms of leveraging the current response to strengthen both pandemic preparedness and health systems, this includes strengthening the case for sustainable investments, mapping and allocating resources, using results from inclusive intra-action reviews and after-action reviews, embedding policies and planning for emergencies into health systems, and vice versa, investing in strengthening health systems capacity for quality and resilient services. Investing in essential public health functions includes increasing both the domestic and global investments in the international health regulations implementation and the implementation of the essential public health functions, includes strengthening professional competencies to address essential public health functions and to implement safe health facilities programs. In terms of the strengthening of the primary health care approaches for health security and universal health coverage, there is the strong need to strengthen community and primary health care levels. Financing public primary health care as well as resourcing healthcare providers to manage emergencies, prioritizing essential health services and adapting service delivery models, and investing in basic health infrastructure and commodities, in particular in infection prevention and control. When we invest in institutionalizing mechanisms for whole of society engagement, this must include systematic mechanisms and capacities for community engagement and multi-stakeholder governance, bringing a whole of society resources and whole of government resources to support capacity building for emergency management, advocating for budgets to support public health systems, sustaining engagement of political and non-state actors, supporting private sector involvement, mandating participation of local governments, and supporting mechanisms for equitable access. In terms of promoting enabling environments for research, innovation, and learning, it is important that these enabling regulatory environments are put in place, providing regulatory support for data coordination, incorporating digital technologies and platforms for health service continuity, maintaining innovative models implemented in pandemics, and promoting research, development, and innovation in risk management, emergency preparedness, and health systems resilience. Increasing domestic and global investment in health systems foundations and all-hazard emergency risk management remains critical. It includes prioritizing investments in foundational capacities, especially for health systems and IHR implementation, facilitating funding to build on gains, leveraging investments in non-health sectors, and increasing the proportion of total government expenditure for health. Last but not the least, addressing pre-existing equities and the disproportionate impact of COVID-19 on marginalized and vulnerable populations remains a high priority recommendation. This includes ensuring that policy and legislative frameworks embed vulnerable populations considerations, guaranteeing access to safe and quality health care by extending coverage, strengthening national social protection systems, protecting essential health workers and workers in the informal sectors, providing special attention to fragile and conflict-affected settings, strengthening development, humanitarian programming, and peace-building connections. These recommendations are supported by the key messages that investing in health is critical for economic security, just as economic development and health development are inextricably linked, so too economic resilience depends on resilient health systems. So WHO, in close collaboration, next slide please, with the national and global partners and with member states, are committed to implementing these recommendations. The commitments include strengthening that whole of society, multi-sectoral, one health, whole of government approach, and leveraging the highest political levels across sectors beyond health to support the implementation of the recommendations. It means promoting health as a central developmental agenda. Health security and economic stability are dependent on the protection of populations. WHO is supporting countries, commits to supporting countries in their reorientation of their health financing arrangements to anticipate and absorb economic shocks more effectively and combine greater flexibility in the use of public funds with strengthened output-oriented accountability. harnessing the health sector and economic recovery process to strengthen and transform health systems in ways that better integrate universal health coverage and health security goals with a focus on resilience in primary health care services and essential public health functions, including an all-hazard emergency risk management approach. WHO commits to applying the lessons learned from COVID-19 in different contexts and documenting progress, challenges, and best practices for cross-country learning as we advance health systems resilience. We commit to intensifying support to address critical foundational health systems issues in fragile and conflict and vulnerable settings, and operationalizing of the humanitarian development and peace nexus in the new ways of working. We commit to reviewing and improving existing assessment, monitoring, and reporting mechanisms for country capacities and progress in health security and universal health coverage, and to strengthening the existing in-country partnership coordination mechanisms while promoting coherent and inclusive approaches to expand primary health care as a pillar of universal health coverage in emergencies. I thank you for your attention.
Thank you very much, Dr. Dalil and Dr. Chungdong, for this introduction of the position paper. And as you heard, dear colleagues, we are committed to take this forward and to take all the recommendations forward with member states and partners in many different ways. And as we are now preparing for a new biennium, it will provide us great opportunities to do so in all the settings, and also to intensify our support and our collaboration with and to the FCV settings. So with this, I have the pleasure and honor to hand over the moderator role to Dr. Gerard Schmetz, Deputy Director of the Primary Healthcare Special Program, who was one of the co-authors of the paper, and acknowledge once again the leadership and support from João Major as well. Over to you, Gerard.
Thank you very much, Dr. Jacob. We can now start with capturing the views from our countries and also from our regional offices. We will have a panel that is subdivided in two parts. The first part is about the lessons learned in terms of resilience from a country perspective. And for that, we will have the member states, Pakistan, Uruguay, Sri Lanka, South Sudan, Slovenia, and Kenya with us. And then we will have the regional perspectives with our esteemed regional directors who will provide their views, particularly following the regional committees in the different regions of WHO. It's a difficult task, that is my task, because it's also about time management. So I will ask kindly to our esteemed and distinguished panelists to try to limit their time to 3 minutes each. But let's start immediately with the first sub-panel with our honorable ministers. And let's start with Pakistan. I think that Pakistan is with us. And I would like to ask Dr. Sultan, Your Excellency, if you could tell us about the lessons learned from COVID-19 and also how you see resilience and how you did maintain your health services during the response. Dr. Sultan, you have the floor.
Excellencies, ladies and gentlemen, I'm just delighted to be sharing my thoughts and experiences in this matter. First and foremost, I think, as has been pointed out, the fact of the matter is that this pandemic actually ended up testing not just resilience in the health sector, but in governments overall, and in the ability of the health system to respond not only in its own domain, but also in domains and spheres well beyond it. So I think one of the things that we found was that in a large country like ours, the first and foremost thing that was required was the ability to convene, the ability to get together and have a centralized data-driven and responsive framework that allowed for the reach of the government in the smallest places. And so in building this resilience, one had to rely on existing strengths. We had to piggyback on existing information systems, on existing delivery systems. And that allowed us to do this in a hurry because obviously there wasn't enough time to build something afresh and anew. So this this piggybacking, this using up or co-opting existing strengths and resources was one important hallmark. The second, of course, was to add a layer of capability or technical or professional domain knowledge into it to ensure the decisions that were being made or the actions that were being done were rooted in science, and not only rooted in science, were agile, that they could change and retool and re-engage in real time to ensure that the responses were relevant to the time. And the third thing that we ended up seeing or realizing was the importance of putting in some future resilience into all these efforts. And that included ensuring that you had the health structure not only structured for the present response, but also to have some institutional memory and institutionalization of your lessons learned so as to go forward. So in our case, we were able to do it through reforming the National Institute of Health, adding a Center for Disease Control, adding a National Health Data Center, a Vaccines and Biologics Center, as well as formalizing of the data flow networks and the response networks that we had built during the COVID time. It's in place now, and of course it will require to be built further and to be invested in, but that's an important endeavor. And lastly, I think in terms of very specifically about vaccination, again, we were able to build and leverage the existing vaccination framework, but also to power it up and to resource it adequately for a large adult vaccination program that could perhaps go on for quite some time. And again, very similar approach was used to build this. So in a nutshell, I think building on strengths and ensuring that whatever you do is rooted in science and keeping yourself coordinated and connected with your implementing partners, the federating units, and so on, was an important lesson for a large country like Pakistan. Thank you very much.
Thank you very much, Dr. Sultan. Very clear conclusions. We need to build on the strengths. I would like to move immediately to the other part of the world in Uruguay, where we have Dr. Daniel Salinas, who will also tell us about the COVID-19 and the way services have been maintained during the pandemic, and what are the lessons learned in terms of resilience. Dr. Salinas? It seems we may have a connection problem, so maybe we will take Dr. Salinas just after. Then I will move back to Asia and ask Dr. Kehelia Rambukwela to tell us about the situation in Sri Lanka, what has been done, what were the strengths of the system on which to build during the COVID-19 to maintain health systems while also responding to the emergency.
Yep, thank you, Chair. Please allow me to respond in context of Sri Lanka's health system being largely founded on the primary health care. We were able to rapidly adopt and bring in an innovative response founded on public health principles to COVID-19. And this is, in fact, our message today for building back better. Primary health care, centered system strengthening for resilience and universal health coverage. Sri Lanka's health system had adopted the PHC approach since 1926 and was, in fact, a contributing case study to Alma Ata Declaration in 1978. From the inception, we have relied on domestic resources for sustainable and equitable health for all. This includes a well-trained health workforce from community level up through higher levels of care, as well as commitments for public financing for fully subsidized healthcare feet at the point of delivery. This is a strong foundation we can speak of, and our health indicators indicate high performances for low middle income groups, and we also compare well with development countries. At-risk children above 12 years, this success has been possible because Sri Lanka has a well-functioning routine immunization program as part of PHC. This includes effective risk communication and community engagement to preemptively address issues like vaccine hesitancy. Further, we have been able to integrate an electronic vaccine tracker to monitor coverage as well as vaccine stocks. This was developed with support from WHO and is now being adopted to monitor long COVID-19. The vaccine tracker will be an important tool to administer the third dose of, as per WHO's upgrade guidance issued last week. We would like to mention here that assistance was provided to Timor to adopt the vaccine tracker, and this highlights the scope for cross-country learning from best practices. The vaccine tracker is an example of how COVID-19 was highlighted the potential of and digital health for service delivery going forward. Sri Lanka has also used telephone consultations for mental health support. This was a service area relatively neglected prior to COVID-19 and to which the health system had to rapidly adopt during the pandemic. An established community component in PHC enable effective community engagement in addressing mental health and psychosocial needs. Physiosocial needs. Sri Lanka has just emerged from an unprecedented surge in COVID-19. The high caseload tested the capacity of treatment facilities and threatened to overwhelm hospitals and intermediate care centers during the initial days. However, as a response, the Ministry of Health, in collaboration with WHO and Sri Lanka Medical Association, supported home care management system to care for the asymptomatic and mildly symptomatic COVID-19 patients. The system triggering mechanism is used to screen patients and assign them to qualified carer for over the phone follow-up until discharge at 14 days. If the patient develops symptoms needing hospitalization, they are linked to the hospital admission system, which assists with assessing ambulance and COVID treatment centers. Pre-intern medical officers awaiting their internship work enrolled to operationalize the program to quickly augment the health workforce with adequately trained personnel. Otherwise sought facility service at the time when these were under severe pressure. For Sri Lanka, our sound foundation has been a key contributor to resilience. Going forward, the potential of digital health innovation and the need to re-examine service organizations to be more responsive shall be key to building back better. The impact of COVID-19 beyond health has emphasized more than ever in importance of whole of government and whole of society approach to health. This is key principle of primary health care approach, and the need is now being felt more than ever for a unified country's response. Such responses have evolved gradually, and we can responsibly assume that with such coordinated response, we will be able to revive the economy as well as restore essential health services. Thank you.
Thank you. Thank you very much, Dr. Ambukwela. Very clear. You have also very well expressed that a solid foundation based on primary health care is certainly key, and that we need also to invest in many things, some linked to innovation like digital health and other important aspects innovative for the system, but also in the communities and working closer to the clients. Thank you very much for this, and let's move now to Africa with our first African country today, South Sudan. And I would like to ask Honorable Minister, Dr. Victoria Ani Major, to tell us about the situation related to COVID-19 and how the system can be more resilient and maintain health services during the COVID-19 response. Dr. Victoria, are you there?
Yeah, thank you for the opportunity. Actually, I just want to make a correction first. I'm the Undersecretary of the Ministry of Health. My minister has apologized, and I'm representing her.
Okay. Okay, please go ahead.
Yeah, strong leadership and governance involving relevant sectors at higher level of the government was an important enabler that ensured there was strong coordination structures and support for the COVID-19 outbreak response, and a strong resilience to essential services while supporting effective emergency preparedness and response. Having a functional active surveillance is something we have relied on, given previous outbreaks of cholera and hepatitis C and other outbreaks, and also preparedness for EBD, as we're neighboring some of the countries that had EBD, gave us also an opportunity to strengthen, to have a robust surveillance system that can respond and also investigate outbreaks. As well as having an existence of public health laboratory. Our public health lab has come a long way. It was well equipped, and the HIV program was well functional, and the availability of a number of gene-expert machines in the country has also helped us utilize that opportunity to test for COVID, especially in Sentinel sites. Also, we had preliminary EBD centers that were eventually converted into isolation centers for COVID-19 cases, as well as provide specialized intensive high dependency care management and follow-up. Community-led systems, workforce and capacities. The flagbearer of the Ministry of Health, the Boma Health Initiative, which was used for antenatal care, for newborn and infant care, handling common diseases like picking up early signs and acute chronic malnutrition, was used at this moment in time as a community surveillance system. Also, people living with HIV networks were used to make sure there's no interrupted supply of ARVs. We've also utilized the opportunity of the multi-month scripting and the communities, people living with HIV networks were helpful in that. These community cadre of workforce are the first line of surveillance for disease outbreaks, and they constitute the force behind community-based surveillance in the middle of an outbreak. And of course, this came also handy during the time of COVID. Having a good national unified data management system. The country has transitioned to data IS2, and that was also an opportunity to make sure that we have dashboards, reports, and other forms of information coming out of such a system on a periodic basis, like daily, weekly, or monthly, and that has helped with decision making and also to effect and improve programming. Also, once such a system is in place and fully functional, the same system could serve as a data management system. And also the country has currently developed the e-governance system where the digitalized COVID certificates are used digitally, and is in a process to link the e-governance to the EAC e-pass, which linking us with the East African community to utilize our COVID. As well, the country have integrated COVID-19 vaccination into existing EPI systems, use vaccinators, which are already in the system, because giving the resource-scarce country like us, we're not able to have a new system, but rather integrate COVID vaccination to existing API systems. And that's about it.
Thank you so much. And lessons very clear with regard to the use of primary health care, the communities, strengthening the surveillance system, and also integration, that is key, as you say, integration of COVID-19 into the routine immunization system. Thank you very much. I've just been informed that Uruguay is back with us, so let's go to Uruguay now, and I would like to ask Your Excellency, Dr. David Salinas, if you, Daniel Salinas, sorry, if you are online. Are you online? Dr. Salinas?
Sí, buenos días. ¿Qué tal? Un gusto de estar en...
Yes, I'm here. I'm very pleased to be here today. We were asked to present our country's experience concerning resilience in the face of the COVID-19 pandemic from a health perspective and also from society. We had significant general cooperation from the very beginning, or even a little before then, as we prepared for the pandemic, cooperating with different researchers, universities, and putting together the PCR test that we needed for on the national level. We coordinated our different national health systems very strongly, which were already in place. This coordination is very important between public and private sectors. This is the FONASA system. But we really integrated the public and private sectors, and we give it particular responsibilities. For example, we integrated the mobile units, which are the systems which allow people to have treatment at home and to have emergency consultations. The idea was to provide care at home through the private sector and also through these mobile intervention centres. Medical consultations could also be given at home, and we allowed the public sector to carry out these consultations. The system that we used allowed us to have WhatsApp remote consultations so that we could follow up with patients from a distance. So this was both public and private, with different medical and other corporations, with researchers, different universities. And with all of these bodies, we put together a special group of experts which advised the minister, and these highly specialized individuals joined a group which was directly providing counsel to the president. It was a group of 50 people, 10 of whom were representatives of public health. This was very significant and allowed us to give real-time advice, which allowed the authorities to take strategic decisions. Advice particularly concerning preventative measures and explaining how to track, detect, and ensure the epidemiological follow-up, as well as identifying positive cases and following up with contacts, waiting for PCR test results. Of course, also those who were in quarantine were at home, but they continued to receive a salary. This was planned for, so we planned to also intervene in emergency situations for for homeless people or for people living in difficult situations, because we needed to ensure food security and protect these people's health. All of these experiences led to a very strong governance when we were planning the expansion. And in a year, we managed to double our capacities. We trained over 1,000 nursing staff so that they would know how to use reanimation devices. We also worked with anesthesiologists and everyone in the emergency services in order to allow for an exchange of knowledge so that in emergency situations everyone would be ready to act. All of the emergency centers had specialists, meaning that we had both the material resources and also the human resources necessary to take charge of the patients. We also had to look at the question of oxygen. We had to import it into our country, and like everywhere, this was very difficult. We also had to manage the question of analgesics, because several countries placed an embargo on the natural resources, so we had to work hard. We needed to ensure that various necessary medications for patients would be available. We also planned for a distribution centre which every week in every centre provided the necessary quantity of medications, and there was real governance in this area. But also should speak of the vaccination campaign, which currently has reached around 7 million doses for 3.8 million inhabitants. We vaccinate anyone over the age of 12, and the aim shows that we are at a level of 94% vaccinated. As for the pediatric vaccination campaign, we are working in this field, and we hope gradually to come back to a normal situation, and we are considering the different forms of quarantine that would have to be imposed. The mortality rates have improved and are better than those in certain European countries. Some countries do not have the same system for checking death certificates. Other important points: the roles of technology, information and communication throughout the pandemic. These technologies allowed us to track via mobile phones, which calculate the distance between individual mobile phones, which allowed us to generate QR codes to show which was the closest laboratory for people to take a test. This application was downloaded by around 70% of the population, thus facilitating us in facilitating the fight against the pandemic. The application also gives you access to a link which allows you to get in touch with the health personnel, access the personal medical records, which contain your PCR test results or antigen test result. And this would work for the first, second, and third doses. As you know, in Uruguay, we are also studying this third dose. We have authorized a third Pfizer dose 90 days after the second dose of a vaccine, an other RNA vaccine, has been received. We have carried out a longitudinal study of antibodies in the blood over the course of this period with a cohort of 1,000 patients, and some vaccinated with Sinovac and 300 with Pfizer, and we saw a proportional reduction from a higher body with the higher level of antibodies with Pfizer than Sinovac. And this is why we are having this third RNA dose. To conclude, many studies have been carried out. In particular, with the pharmacovigilance group, following the undesirable effects and communication is easy using WhatsApp, communicating over the web, and this allows us to provide greater clarity on the different undesirable effects. I will finish because I can see that I'm running out of time. But just to look at the big data, we are following up after the first vaccination to then see whether people have contracted the disease, whether they have become ill, whether they were hospitalized, and also whether they died. This allows us to see how efficient the vaccines are and how efficient each different vaccine is, so that we can see what measures we should or should not take to see whether or not they are efficient. It seems that all measures are efficient and avoid hospitalizations, emergency hospitalizations and deaths. And this is all very clear. %33% have now had this third dose. And we expect more data for 5 to 12-year-old children, and we are also awaiting information concerning the 6 months after the last dose of Pfizer.
From the beginning, you have been successful in terms of adapting your system to the disease, and you had also a lot of flexibility in your way of working, including contracting the private sector, introducing telemedicine, working in real time improving your governance mechanism and also ensuring a close governance, including in your last part with regard to vaccines and the efficiency to make sure that you are on the right track. So thank you very much. And now we will move from Uruguay to Europe, to Slovenia, where we have Dr. Vesna Petric, who is with us today. And Dr. Vesna?
Thank you very much, Chair, Director General, Dr. Tedros, Susanna Jakob, the Deputy Regional Directors, distinguished ministers, ladies and gentlemen. It is a privilege for Slovenia to have this opportunity to speak and present WHO European region in such an important event. We are holding at the moment a presidency to EU. And we have put strengthening health systems in EU, but also globally as a key priority of our presidency. The COVID pandemic has underlined the importance of improving coordination of global actions in strengthening health systems resilience and ensuring universal health coverage and health security. We all now understand what are the challenges. I think we do. We all aim to make our systems resilient. This is what we say. But how can we do this fast? Where are the opportunities? Let me focus on primary health care, certainly such an opportunity. Primary health care has always been at the core of strengthening health system and still is in many countries in European region. It brings healthcare and preventive services close to where people live and best addresses the needs of population, including those most vulnerable, in particular so if it works together hand in hand with public health. We have learned during pandemic that effective primary health care allows health systems to adapt and respond best to such complex situations. But primary health care has proven also to be a highly effective and efficient way to address the main causes and risk factors of non-communicable diseases, as well as, we believe, other emerging challenges of the future. With its emphasis on promotion and prevention and by addressing health determinants hand in hand with public health, as I said before, but also with civil society, it contributes in particular to equity in health and to development of local communities. To succeed with our common aims in achieving universal health coverage and accomplish health-related SDGs, we also think primary health care is crucial. The challenge now is how to make strengthening primary health care a reality, not only in some countries, but globally. Special focus should be on investing in primary health care capacities and on further integration of services and working combinations of all professionals that are working at primary healthcare level. And here I'm not speaking only of doctors and nurses, but all the other professionals like psychologists, social care workers that are linked to primary healthcare and contribute, in particular, we're working with vulnerable groups. Moving forward, we should focus also on assuring supportive IT services and telemedicine where needed, and on upgrading mental health services at primary health care level. The need for having strong and responsive mental health services close to people at primary health care level is a lesson learned during the COVID pandemic. Many member states from European region have a long tradition of strong primary health care. We could and should contribute by sharing our experiences and working with other regions in developing innovative solutions. Let me conclude by emphasizing that health today is high on the political agenda of governments and in the focus also at many international fora. For example, this month, investments in health will be discussed by Minister of Finance at G20 in Rome, with ministers of health also participating in the discussions, how best to make our health systems resilient to future threats. We should build on this momentum and strive that the investments are strategic and leading to sustainable changes and resilient health systems worldwide. WHO we see as key in assuring such a strategic approach, and recommendations presented today are an important step, we believe, in this regard. Thank you.
Thank you. Thank you very much, Dr. Petric. Very clear also your positioning, and also we understand that you also represent the EU in a way during this presidency. You put forward primary health care and equity as certainly part of the solution, and you tell us clearly that we need to push this agenda forward and make it a reality. Thank you so much. Now let's move again to Africa, where we have our Honorable Minister from Kenya, Dr. Mercy Mwangangi, who will also tell us about COVID-19 and resilient health systems maintaining services during the pandemic. Dr. Mercy?
Thank you, Gerard.
Thank you very much.
Let me begin by saying that Kenya wants to congratulate WHO and all the thought partners who have made it possible for us to launch this position paper today. I think the paper is timely considering where different countries are in their journey in fighting the COVID-19 pandemic. And so we are quite excited as a country to be able to enjoy all the insights and all the evidence and all the really, useful recommendations that come out from this position paper. I think it's important for me to start by saying we do take note that this paper does a good exposition in terms of identifying the gaps that have been there in terms of resilience of health systems. And what is more important is beyond identification of these gaps, the paper does, create a better understanding. And I think this was, highlighted earlier in the beginning introductions, where I believe it was Mr. Ryan who said that the key thing to focus on right now is the design of our healthcare systems, and that we cannot simply pump in more money or more resources, and that what we need to focus on is on the design. And so in this regard, I'd like to share with you some of the key lessons and thoughts and insights that Kenya has gained as we fight against the COVID-19 pandemic. And for us, the first one would be a clear recognition of the interdependency between public health systems and other sectors within the country. I think this pandemic has painted a very clear and perhaps sometimes caustic picture on how important those interrelationships are. And so recognizing this and gaining insights of this interdependency in Kenya as we move forward, as we take through the recommendations from this position paper, part of our redesigning and rethinking of the system will really be pegged on an appreciation of this interdependence. And I think countries before me, Uruguay and Pakistan, have highlighted the need to actually have those platforms that actually call for multi-sectoral action. I can say that the Ministry of Health could not have done it alone when it came to the COVID-19 pandemic, and that there were different systems and platforms and committees and task forces that have been put together that really reflect this interdependency and that reflect this multisectorality when it comes to dealing with the COVID-19 pandemic. And so we intend to integrate this as part of our continued building of the resilience of health systems. I think a key thing and a second insight that we are taking from this experience as a country is that it becomes very important, as Mr. Ryan said, the design of the system. And for us, as we design the system, we have three key approaches at the back of our heads as we think about system design. And the first one is, as I've highlighted earlier, a whole of government approach. Whatever mechanism you put in place, be it investments in human resources for health, be it investments in information technologies, be it investments even in lab systems. I think this COVID-19 pandemic, particularly for Kenya, has demonstrated that interdependency and that need for a whole of government approach. Numerous examples have been shared by member states here. In Kenya, the situation is not any different. We did end up leveraging on laboratories that exist in the agricultural sector, that exist in the livestock sector, beyond the health sector. And so it's very clear that as we build towards system resilience, particularly for progression towards UHC and health security, we must ensure our plans embed a whole of government approach. Secondly is the systems approach to how we do business in the public health area. I think it's become very clear that investing in a single input, investing in a single programmatic area may not be enough to secure us and to ensure that we move the agenda of UHC forward and that of health security. And so as government, as a country, Kenya, we are looking to ensure that we do adopt a systems approach as we move this initiative forward. And then also to remember that I think one of the lessons that most countries have learned is that agility is very, very important. As you design a mechanism of intervening against a pandemic, your mechanism must be very dynamic and must be very agile. And so I think that's an important thing and consideration that member states need to take into account. I think a big third issue as an insight for Kenya that has been highlighted is the clear inequities and inequalities that exist in the health system and how different interventions can exacerbate some of these inequities. And this could be both internal or external when we get into the issue of vaccine appetite. And so what we're saying as Kenya is that we have to ensure one of the key considerations that we have as we design for the future, as we reprogram and reimagine how the future would look like, has to be the issue of inequities. How do our designs in investments in human resources avoid these inequities? How do our design in information technologies and health information systems avoid these inequities? How do our designs when it comes to pandemic preparedness and all the pillars that come with that avoid inequities that have been clearly demonstrated in the COVID-19 pandemic? I think the other fourth, and perhaps this would be my final lesson as a country, what we've learned is that integration is key. And I'm glad that our fellow member states, Pakistan, did emphasize on this. Integration is key. And I must say Kenya was particularly lucky in the sense that when the pandemic started, we were on the way of setting up a UHC program. That was a vision of our president. And so in that UHC program, we'd already set aside investments for human resources for health. We'd already set aside resources to ensure we recruited more staff. And so when COVID hit us, what we did is we simply recustomized this staff to ensure that they were able to also provide some surge capacity for COVID-19. And so it's this integration and sort of this interlaced and interwoven thinking that is necessary as we move forward. And so for us as a country, we really do appreciate this position paper. We feel it will be quite instrumental as we build our recovery plans, as we see how Kenya can emerge from this and other member states can emerge from this pandemic stronger. And of course, always remembering our primary objective when it comes to advancing the UHC agenda. And then, of course, ensuring that we are secure and that the public health good, remains the key objective. And so these are sort of the summary points in terms of what we've learned as a country, and they echo really what each and every member state has come before me to share with us today. Thank you, and over to you, Gerald.
Thank you so much, Dr. Mercy. Very clear messages related to the design, to the interdependency, and also to the needed intersectoral action, whole of government approach, system approach. You insisted also a lot on the workforce, and I think that we had the same from our lead colleagues, the DG, the DDG, and the EXD for emergencies. Workforce is key in all this, and we need to make sure that the workforce is there in quantity, well-trained, and also that it's not exhausted by the response. You insisted also a lot on the different public health measures to be taken, and I think that this is really well taken. Thank you very much. Now I would like to move to the second sub-panel that is with our esteemed regional director, and to ask them the question about what we can do differently to build back better and fairer health systems to better resist to future pandemics. And we have with us different regions, EMRO, CIRO, Euro, AFRO, and PAHO. And I would like to start with the East Mediterranean region with Dr. Almandari and ask him the question about what we can do differently to get better and fairer health systems based on our experience and with regard on the recent discussion you had during your regional committee in the EMRO region 2 weeks ago. Thank you very much. Dr. Almandari, you have the floor.
Thank you very much, Gerard, for leading this important and very stimulating discussion. And I'd like to express my sincere thanks on behalf of EMRO to my dear brother, Dr. Tedros, and the team, as well as member states who have really pushed us towards strengthening our systems in that aspect. As you said, Gerard, we have concluded our regional committee meeting last week. It was full of optimism, positive spirit to move forward, particularly after spending almost 2 years, with this COVID-19, with a lot of lessons, as their excellencies have mentioned, in their remarks. As we all know, I will not repeat myself a lot, but, on the remarks that have been given, COVID-19 has had a severe and significant impact on population health across the world, regardless of that country, well-resourced or poorly resourced. In addition, to its direct impact on health in many countries, as I said, both the pandemic response and, the disturbance that it has caused to all functions of the healthcare system. That was obvious in the drop in the number of the immunization rates, the drop in the utilization of other services to communicable and non-communicable diseases. So the pandemic, by all means, it has revealed, the lack of resilience in our system. Even in countries that are well known of strong health systems, well-resourced, well-equipped, let alone systems in countries that are suffering from conflicts, instabilities, and emergencies, like the one we are having here in the region, and which led into a very worsening health situation in many of the countries. Now, given the fact that, the short-term needs, as well as the long sort of needs and increase in the services, particularly, like, for example, on services for mental health, which we all agree that it has to be really well strengthened to deal with any type of emergencies, let alone the usual service that we should provide. I think now it is very important to restore service delivery and functioning of the system as soon as possible, and not to miss anyone and leave no one behind. Now, yet a return to the pre-epidemic state or pre-pandemic state will not be sufficient, because the pandemic has both demonstrated and exacerbated, in fact, existing weaknesses in our systems, as have been mentioned by their excellencies. And it has highlighted the lack of resilience in many of the systems. It has also shown that when it comes into the universal health coverage and security, as Dr. Tedros have mentioned, these are two sides of the same coin, which in turn, has underlined the need for stronger integration of emergency preparedness and response into the health systems. And this has been well stated by Mike in his remarks, in the introductory remarks. Now, the goal for us in EMRO is, that we must be building our systems in a better and fairer way, and make sure, through transformation of the system in a way that to increase their resilience and at the same time maintaining their equity. So I just would like to share some suggestions at a global and national level. The first one, that there is a need for investment in health systems, and this has been reflected by all member states in different meetings, regardless of the level, and strengthen the system based on the primary healthcare concept, which we all agree that it is the first line of managing whatever emergencies, including this pandemic, and give that primary healthcare approach, which is rooted in equity, social justice, solidarity, and ensure a broader rule of people and engagement of communities and individuals in their own health and their life course. The second point, it will be very important to strengthen the essential public health functions and have all hazard, emergencies, and disaster risk management plans and programs, developed and emphasized and monitored, like the IHR. The third point, it will be important to facilitate and improve global transformation in terms of sharing the international and regional coordination and resource sharing, for instance, when it comes into supplying like the personal protective equipments, which we faced at the initial weeks and months in the region and around the globe. So this is another important point. Finally, it will be very essential to learn from the current epidemic and where necessary to examine the adaptations that we made during the initial response to maintain essential services. And there are a lot of success stories that we can learn from, as well as to determine which should become a permanent feature of the rebuild and transformation of our system. I would like us to conclude, Gerard, with our remarks on the context here in IMRO, to provide the necessary support to our member states. I have just 4 recommendations to our member states, and we have in fact started discussing and working on this with all health authorities in the region, including the discussion we have had last week. The number 1, investing in institutional mechanisms for whole of society engagement. And we have heard many successful stories in the remarks from their excellencies. We have to work hard on promoting enabling environments for research, innovation, and learning. Otherwise, we will miss the opportunity of documenting whatever challenges that we faced, whatever success stories that enabled us to overcome these challenges. We have to, number 3, to have increase the domestic and global investment in health system foundation and all hazards emergency risk management. Otherwise, we will not be able to rebuild our systems at a stronger and resilient manner. The last is, addressing pre-existing inequities and the disproportionate impact of COVID-19 on, marginalized and vulnerable groups. And we have many here in IMRO. And this is an important point that we work. I would like just to conclude, Gerard, that we are working to implement a recommendation, in IMRO, that was developed by our colleagues here in IMRO, as well as supported by headquarters with member states, a toolkit for health systems recovery from COVID-19 pandemic. That will provide guidance to our member states and partners as well on how to assess and implement the recovery plan in a structured way, built on evidence and a scientific manner, with an acknowledgement of the complexities and non-linearity, of the pandemic process, and make sure that we move ahead, strive the ladder in a very stable and strong manner. That's all from my side, Gerard. Thank you very much for this opportunity.
Thank you. Thank you so much, Dr. Amandari. Very, very clear. You have clearly assessed in the region the problem and the need to integrate preparedness into the health systems and response into the health systems, and to adopt primary healthcare approaches and the essential public health functions as driving the transformation and the reform of health systems. You also mentioned the global coordination that is needed. You have a set of recommendations to the member states that are very clear and also aim at addressing inequity, and also a toolkit at the disposal of your member states. Thank you so much, Dr. Almandari. I would like to move now to Southeast Asia and ask Dr. Singh for her own views and maybe also the feedback from the regional committee that took place a couple of weeks ago. Dr. Singh?
Thank you very much for that. And thanks for making us participate in this very productive meeting, where we get the opportunity to listen to various health ministers from across the globe and hear their views and listen to their sharing of experiences. As far as the WHO Southeast Asia region is concerned, we are well placed to realize the 7 interconnected medium and long-term actions identified in the WHO position paper. Substantial political commitment and action is already evident across the Southeast Asia regional countries with respect to 7 actions identified in the position paper. Political commitment to these actions is evident in the 2 CR ministerial declarations, and you referred to the regional committee. I take the declarations from 2 regional committees, the regional committee we had this year and the regional committee of last year. Both of them focused on COVID. One on collective response to COVID-19, which was held last year, and this year's ministerial declaration, followed by a resolution in the regional committee, talked of building back better, as adopted by the various ministers who participated. The region's recently adopted declaration to build back better provides a very detailed outline of what exactly is needed. I take this opportunity to highlight 5 priorities. First, ensuring political leadership and accountability to coordinate a whole of government and whole of society response. Second, reorienting health systems towards comprehensive primary health care through increased public investments. Third, ensuring integration of public health emergencies and disaster risk management strategies, as well as strengthening surveillance and preparedness capacity at the primary healthcare level. Fourth, committing to closer engagement and empowerment of communities with respect to maintaining the delivery of essential health services and public health programs. And fifth, using COVID-19 interaction reviews and the new Universal Health and Preparedness Review to prioritize actions aimed at strengthening health systems resilience. The pandemic exposed serious gaps in the health systems and emergency preparedness across all countries. At the same time, the level of innovation and energy to address health system challenges and gaps has also been unprecedented in scale. Member states, experts, both at the global and regional level, and the WHO-UHC colleagues have met today and reviewed lessons learned from COVID-19 to identify the road forward for health security and health system resilience. While it is imperative that we build better and fairer health systems, we must also ensure that these systems operate in a social political environment that is health enabling and which is committed to achieving a fairer, healthier, and more secure future for all. That is all for the moment, Gerard. Thank you.
Thank you very much. That's all, but that's also very clear. You have clearly priorities in the region: political leadership, primary health care, integration of emergency and preparedness, working with the communities and strengthening resilience. Very clear messages. And I would like now to move to Euro, where Dr. Natasha Azzopardi-Muscat will tell us about the situation and probably also the recommendations promoted during the regional committee. Dr. Natasha?
Thank you very much, Gerard, and it's my pleasure to represent the WHO Regional Office on behalf of Dr. Hans Kluge, who's on duty travel today. And I really enjoyed listening also to all the interventions, and I will complement the intervention made by our colleague, Dr. Vesna Petric from Slovenia. We had our regional committee meeting last September, and I would like to refer to 2 main documents which we had on the agenda. On our political day, the first day, we launched the report of the Pan-European Commission on Health and Sustainable Development, an independent commission chaired by Senator Mario Monti. And this commission made it very clear that in terms of the lessons drawn from the pandemic, the report is entitled Drawing Light from the Pandemic, there is a crystal clear call to promote One Health, to go beyond the silos, not to leave the fractures which we have in society unheeded, and ensure that the health of the vulnerable is really prioritized, and also a clear call for strengthening the resilience of health systems, not least by paying attention to some areas of the health system that traditionally may have been neglected, such as public health, primary health care, and mental health. On the second day of our regional committee, the main item that we had on the agenda was indeed primary healthcare. Why? Because during the past months, working closely with countries, we saw that a number of countries really took the opportunity to transform their primary healthcare systems and to learn lessons from the pandemic. We identified 4 key trends. The first one, and I think this is really important as we build forward, is the dual track health system, the ability to surge and respond to a protracted emergency whilst not losing sight of the need to continue to provide essential health services. The second trend is that multi-modality healthcare is here to stay. There should be no time lost over arguing whether it is better to be face-to-face or digital. The pandemic has taught us that there is room and space for both, but one does not exclude the other. The third trend is the need to find ways to identify early on the vulnerable persons and ensure that we reach out to them. And the fourth trend is that if we really want to strengthen primary healthcare, we need to invest in multidisciplinary teams. So for us, primary healthcare going forward goes beyond ensuring universal health coverage, which is something we have known for a long time. But primary healthcare also needs to be part and parcel of our preparedness and emergency response, which far too often has been linked to hospitals and the emergency services linked to hospitals. And thirdly, we must ensure that our primary healthcare systems go beyond the pure biomedical approach, take on a wider psychosocial approach, and in that way, we can really work on the pillar of improving health and well-being. For this to happen, we must invest in the healthcare workforce, the multidisciplinary health workforce. In order for primary healthcare to be prestigious, we must ensure that we also carefully invest in infrastructure and digital health systems that will make it possible for primary healthcare to network well with hospital networks. And finally, we need to continue to advocate to make primary healthcare governance and monitoring on the agenda, because often this is not given enough thought. And for this, we need to continue to work with the political leadership in countries. This will be the key thrust of our regional program for implementation in the coming biennium, and it is fully complementary to the position paper that you have launched today, for which I extend our heartfelt congratulations from the Euro region. Thank you.
Thank you very much, Dr. Natasha. Also very clear, you have assessed clearly neglected areas, public health, primary health care, and mental health, and you have identified the different threats. You recognize that so far primary health care was mainly on the road to UHC, but there is a need to make clear that primary health care is also part and parcel, as you say, of preparedness and response. And you insist also, of course, on working in close collaboration with hospital networks, and very importantly, like most others, in investing in the workforce. Thank you so much. And we move now to the African region, where Dr. Geoffrey Bizawara will tell us about the way it has been handled during the regional committee in August. Dr. Bizawara?
Thank you very much. Thank you very much, Gerard. Excellencies, ladies and gentlemen, apologies from Dr. Masidiso Moeti, who is unable to be in this meeting, certainly for other urgent duties. Within the African region, certainly we see that even in the darkest clouds, there is always a silver lining. A lot of challenges have been mentioned regarding this COVID pandemic, but we are taking a look at the opportunities which this pandemic comes with. In most of the African countries, this COVID-19 has provided the highest level of advocacy for health, which we have never received before. In a number of countries, we have national task forces for COVID, which are sometimes chaired up to the highest level of the land, that is by the heads of state. This is an opportunity of putting health at the highest level possible. Populations and stakeholders have come to understand that although health may not be everything, but without health, everything almost becomes nothing. Within the African region, this COVID-19 pandemic has provided an opportunity of promoting health in all policies, where issues of health are not left with ministries of health alone, but it is going beyond involving the whole of society, the whole of government approach. There are a number of things, for example, if I can limit myself to the services, where COVID-19 has been a source of expanding services. For example, the emergency and critical services are being expanded within the African countries. Infection prevention control, which is part of the quality of care improvement, there is an expansion in that area. We are seeing areas, for example, innovations, a lot of innovations and research, including the use of digital health, which has increased or gotten deeper within the African region. The issue of local manufacturing has become prominent within the Africa agenda. All those have been catalyzed by the COVID-19 pandemic. So we feel that we need to build on those positive, what I can say, positive experiences in quotes, to see how best can we use these lessons to build more stronger, more resilient health systems. Excellencies, including the High Excellency, the Minister of Health from the Republic of Kenya, has mentioned very important points, which even the African region at the WHO Secretariat is taking forward. I will not repeat those points, but also our Director General mentioned the issue of not doing same things and expect same things in the same way, expecting different answers. We are looking of the changing of the how to do things differently. The issue of the health systems reform is on the redesign is top onto our agenda, which is part of the African region transformation agenda. How do we do things differently? How do we redesign our health systems to address the current challenges, future challenges, but also to address the future aspirations beyond the addressing challenges, the aspirations of the people of the African region. Because of the time, I will not go into the details, but it includes issues of the health workforce, issues of having the surge capacity. We've seen that even if we didn't have adequate health workforce, but maybe we need to have enough, but not even enough, we need to have the surge capacity. So those and many others are the things the African region, the member states, together with the Secretariat, are looking forward, and is part of our next program budget for the next 22, 23, and in the medium term. Because of the time, I will beg to stop here. Thank you very much.
Thank you very much, Dr. Bizobowa. Also very clear and a lot of recommendations that are similar to the other regions. You insist also on the foundations of the health system and the need to invest in it for both universal health coverage and health security, better preparedness. You insisted also, again, like many others, on the workforce, but also importantly on infection prevention and control. And I think that it is really also recommendations that go in the sense of the position paper per se. Now I would like to move back to the Americas, and we have with us Dr. Barbosa, from the PAHO office, Pan American Health Organization office. And Dr. Barbosa, I would like to ask you the following question. What should be the role of global communities and national stakeholders in building health systems for the 21st century challenges?
Thank you, Gerard, and good morning. It's a pleasure to be here on behalf of our Regional Director, Dr. Carice Etienne. Gerard, the path to recovery from the COVID-19 pandemic requires intensified actions to control the pandemic, the rapid and equitable deployment of COVID-19 vaccines, and mitigation of disruptions in the provision of essential health services to protect the health gains. And a progressive transition from pandemic response to recovery requires a renewed focus on building sustainable, resilient health systems informed by the COVID-19 response. Within this context, PAHO-AMRO welcomes the position paper on building health system resilience towards the universal health coverage and health security during COVID-19 and beyond. Resilience is an attribute of a well-performing health system. Important empirical lessons from the Americas have been learned during the COVID-19 pandemic. The Honorable Minister Salinas shared with us some of the very important lessons from Uruguay, and many countries in our region also working on the critical determinants of health system response and resilience that will inform future decisions and action. Firstly, long-standing structural deficiencies in health systems that are not addressed impact response capacity and public health outcomes in times of a public health emergency. Secondly, effective and coherent governance and leadership is critical to ensure consistent planning of public health interventions, including the integration of individual, collective, and population-based health services, and public health preparedness and response plans. And thirdly, health systems have capacity to accelerate innovation, optimizing the mobilization and utilization of limited resources to address health needs. Health service delivery was reorganized and expanded in all 51 countries and territories in the Americas. Digital health technologies in service provision was fast-tracked. Worker management, task sharing, and workforce planning was transformed. And research and knowledge translation rapidly generated new health technology, saving lives. As evidence from these lessons, there is an urgent need to sustain action and invest to build resilience in health systems to protect and promote health, as well as to support social and economic development. In September, the PAHO-AMRO Regional Committee adopted a strategy for building resilient health system and post-COVID-19 pandemic recovery to sustain and protect the public health gains. This strategy is fully aligned with the WHO position paper released today. The PAHO strategy calls for the transformation of a health system for universal health coverage based on a primary health care approach to accelerate pandemic recovery, recuperate and sustain public health gains, addressing exacerbated inequities in health. It urges strengthened leadership, stewardship, and governance with a renewed focus on the essential public health functions. It recognizes the need to strengthen capacities of health service delivery networks to expand access and improve preparedness and response to public health emergencies. And it highlights the need for increased and sustained public financing in health and social protection, addressing the social, environmental, and economic determinants of health. At the request of our member states, PAHO WHO will be convening a commission and technical committee in the Americas with the active engagement of governments, health and social sectors, private sector, academia, and civil society to rapidly move forward with the implementation of this strategy. It is only through collective action and with the support of the global community that we can take the necessary steps to prioritize, transform, and invest in health system so that we can protect and promote the health of all. Thank you, Gerard.
Thank you very much, Dr. Jarbas. Also very, very clear. I think that the different regions are on the same wavelengths. You have insisted on different priorities, of course, increase response capacity, but also better plan primary healthcare interventions, better include preparedness, and also optimize, as you say, with increased usage of innovations such as digital health. Then you have the new resolution and the call to member states that is clearly in line with the position paper. In the interest of time, and I would like to thank all the panelists. I think that from country perspective as well as from the regional perspective, we have a clear support to the position paper and certainly a clear avenue in terms of what to do in the near future. Thank you very much to all the panelists. I would like to give the floor back to Dr. Susanna Yacob. Thank you very much.
Thank you very much, Gerard, for so ably chairing the previous panel discussion. And let me thank also for all the participants joining us in the panel, in particular to Ministers of Health of Pakistan, Uruguay, Sri Lanka, representative of South Sudan and Slovenia. Special thanks to the regional directors EMRO and CEARO and representatives from Euro, AFRO and AMRO. So we arrive to the last stage of this meeting today, and we do some summing up together with my colleagues from the Emergency Division. And I have the pleasure and honor to pass the floor first to Dr. Joao Majur on behalf of the Emergencies Division. Joao, over to you.
Thank you very much, DDG, and thank you, colleagues and excellencies, for this very fruitful discussion on the role of the PHC in making the health system more resilient, and also the linkages between the PHC and the health security. As my fellow speakers and participants have highlighted, now is the time to apply the lesson learned from the current pandemic to other past public health emergencies. Applying these lessons, a major priority that has been set by WHO member states at all recent high-level panel. In the WHO 73, by speaking about the importance of health emergency preparedness and the link to health system and the PHC, and the last assembly by discussing the WHO, strengthening WHO in pandemic preparedness and response, but also calling for a special assembly in end of November to discuss the future of pandemic preparedness and response, including strengthening health system and primary health care, and looking for more resilient of health systems. What we learned from all the member state discussion, but also from all the panel recommendation, is that the world cannot be prepared unless that every country is prepared. This is something that became now understood by everyone, and there is a big need to invest in country preparedness. But we know also that country cannot be prepared unless that all communities are prepared. And we saw it in various situations where the national figures in preparedness are acceptable, but when you go to the local and the subnational level, you find big discrepancies. All the panels also agreed that every single global threat starts at the community level. And unless we equip communities and equip the primary healthcare serving these communities to detect and contain threats, we will continue to have national epidemics and also global threats and the pandemic. But of course, this will not just happen because we want it to. This will require strong and ambitious political leadership at the national level and also at the global level to address the weaknesses that we are facing in national preparedness and in global preparedness. The world's worst global health crisis in generation present us with an opportunity to do things differently, but also to come together in more solidarity to be better prepared for the next pandemic. Dr. Tedros always says the pandemic is not a matter of if, but is a matter of when. And we need to be prepared for the next one. And investing more in health system and in PHC a key to the global preparedness. Again, thank you very much for your leadership, Susanna, in this work. Thank you all colleagues who contributed to this paper, and happy to work closely together to its implementation. Back to you, Susanna, and thank you very much again.
Thank you very much, Dr. Majur. Dear colleagues, there are very important takeaway messages from you today, which underlines also the timeliness of this paper and this work, and you also confirmed that we are on the right track. During this short time in summing up, we cannot do justice to the richness of the discussion, but let me highlight some key issues that came up during the course of this meeting. First of all, you emphasized that we need to build on the strength of the health systems and constantly analyze the upcoming new developments, new practices, and integrate them as new learning right away into the system. Secondly, you emphasize the need to build on primary health care towards universal health coverage with strong public health funding and use the whole of government, whole of society approaches as an integral part of primary health care together with community engagement and the work on equity. Thirdly, you emphasize the need to use innovations, scale them up, including the digital way of working and also telemedicine. Fourthly, you have also highlighted the need to have adequate workforce who are well trained for all the important functions during emergencies and also beyond emergencies. Fifthly, you emphasize the need for flexibility, agility, adaptability, and sustainability of the system. That was also emphasized by Mike in his introductory remarks. Then sixthly, you strengthened our belief that we are on the right track with our vision to strengthen primary health care coupled with public health and preparedness, and the interdependence between these functions and the sectors are critically important. And you also emphasize the need to invest in health systems based on primary health care, but based on equity, social justice, and solidarity. And many of these messages are already integrated in our paper, and your messages will clearly further strengthen our work as we move forward. And some of the key messages that you also highlighted but are already in the paper are the need for interdependence with the whole of society, whole of government approach, the system approach, the need to address the inequities and inequalities, be it information technology or workforce or preparedness, and finally, the fact that integration is key. And you reassured us that we are on the right track with this resilience work. And as Joao just mentioned in his summing up just now, that the world cannot be prepared unless every country is prepared, and countries cannot be prepared unless all the communities are prepared. I think this is the most important rationale behind this work. So as we move towards recovery and transformation, we must reaffirm WHO's commitment to support member states and communities in relaunching progress towards UHC and health security. Using the lessons learned from COVID-19, we will continue to engage at the highest levels to ensure a multifaceted approach to strengthening health system resilience and whole of government, whole of society engagement, to ensure sustainable action on rebuilding the health sector with a focus on addressing system-wide gaps to ensure health security by mitigating losses in progress towards SDGs. We will definitely support countries to harness health sector and economic recovery to strengthen and transform health systems through a primary healthcare approach and adequate investments into essential public health functions to achieve UHC and health security objectives in tandem. And finally, WHO will intensify its support to bring together humanitarian and development stakeholders to address critical foundational health system issues in the FCV settings. I look forward to seeing how this work shapes recovery and transformation efforts and helps to build the resilient health systems required to face the challenges of the 21st century. With this, I'd like to thank you again for your participation and input, and now close this meeting and wish you a nice week. Thank you very much.